Alrighty. So we'll start out with psychotherapeutic agents. We talked about several classes, but I'll start out with benzos. We've spoken about benzos before, and actually you had them in Pharm 1 as well. Obviously, you know that you must check respiratory depression, certainly respiratory status. They're also very uh, habit forming, and the good news is if you're giving them for the two things that they're most widely used for, which are anxiety and status epilepticus or seizure disorders, they work very well because they work very quickly. Unfortunately, you can't suddenly quit taking them, and you must certainly taper them very slowly. Anything that has a profound effect on the central nervous system must be weaned. Um, Benzos certainly cause respiratory depression, but a lot of these psychotherapeutic agents have a profound effect on the central nervous system as well. Flufenazine, if your patient is on flufenazine and they report dizziness and shortness of breath, something else you may also think about is cardiac involvement. And then you definitely either want to get an EKG or make sure they're on continuous EKG readings as well. Chlorpromazine is another drug that we spoke about that's used for schizophrenia. Unfortunately, these drugs, particularly chlorpromazine, can cause tardive dyskinesia. If your patient begins to exhibit signs of tardive dyskinesia, certainly those doses can be lowered because if your patient has these symptoms or chronic use of these medications for a very long time, they could develop chronic tardive dyskinesia that is irreversible. These drugs that treat schizophrenia and some of the other drugs that we've spoken about in this semester can take several weeks to months for the symptoms to improve. Unfortunately, they don't always improve entirely, and particularly in this patient population, um, you have to watch them at all times. Um, Bipolar disorder is another disorder that we spoke about as far as these antipsychotics. Risperidone is one of the drugs that can have a beneficial effect on bipolar disorder. Unfortunately, when these patients are in their the manic upswing to the bipolar disorder, they like that the feeling of energy versus that deep depression. So it's during this time when they sometimes are known to not take this medication anymore because they like that the feeling of elation. The Risperdal is given sometimes in combination with other drugs because the Risperdal can actually take the edge off of the extreme combativeness or agitation as well. Like I mentioned before, bipolar disorder, patients who have bipolar disorder have a very hard time navigating the medication because they do have a lot of side effects, particularly lithium. Um, Certainly, when they are experiencing these very highs, they really don't think anything's wrong with them, and so these are the times when they feel that they may be normal and don't need the medication anymore. Lithium is also one of those medications that has a side effect profile of muscle aches and pains. Remember not to give your patient NSAIDs because NSAIDs can actually increase the serum levels of lithium and they can become toxic as well. Valproate is a medication we also provide for um, bipolar disorder. Valproate has a tendency to cause thrombocytopenia. So if your patient you observe your patient for any sort of bruising that's over soft tissue areas, certainly that could be an indication of thrombocytopenia. Lamictal, we spoke about lamictal, and one of the side effects of lamictal can be Steven Johnson syndrome. And anytime you see a rash, you always think Stevens-Johnson syndrome. So always, if your patient has a rash, you may need to look farther for other uh, symptoms or side effects of lamotrigine or lamictal. Um, Lithium has a couple of disadvantages. It can also cause your patient to wash out their sodium and their fluid as well. So it may be something that you monitor, whether it's electrolytes, fluid and electrolytes, while your patients are on lithium. Olanzapine, Zyprexa, is a medication that's often seen given acutely in the emergency room. You know that this medication is working if your patient's psychotic symptoms decrease. I mentioned this, I know, during our initial lecture on antipsychotics, but there's three things we look for in patients. Number one, you look for the fact that is the medication you're giving them relieving their symptoms. In the case of antipsychotics, are their psychotic symptoms decreasing? Number two, you look for any side effects. For instance, um, does your patient have any bruising over soft tissue areas? So you look for, is the medication doing what it's supposed to? Do you see any adverse side effects? And then, there's also a gold standard that you can also draw serum drug levels. So, particularly with lithium, you can always tell if their serum levels are normal or too high or too low, to know that if you need to decrease it or increase it as well. Chlorpromazine, as well as any other antipsychotic medication, have a profound effect on the central nervous system. Um, Never ever abruptly withdraw this medication. Certainly, you can imagine if you abruptly withdraw this medication, one of the side effects would certainly be insomnia and or agitation. So that's something you watch for during in a patient that has been abruptly discontinued themselves on the medication. Let's see, obviously alcohol should not be used in patients that are taking medications that depress the central nervous system, because alcohol will cause an increased central nervous system depression. I think we talked about that probably a lot this semester as well. Clozaril, clozapine also causes bone marrow depression. Anytime your patients are on these medications, monitor for signs and symptoms of bone marrow depression as well. Olanzapine, Zyprexa, has an effect on blood glucose. Always monitor for either signs or symptoms of um, blood glucose elevations as well. I mentioned benzos earlier at the start of our conversation today. They treat generalized anxiety. Certainly, they should be used with caution in the elderly, and certainly in seizure disorders as well. Wrapping up our conversation about these antipsychotics, schizophrenia, we talked at length about. We have negative symptoms and positive symptoms. Negative symptoms are those symptoms that have lack of judgment, poor judgment, lack of self-care, poor self-care, lack of poverty or lack of speech, poverty of speech. And then, of course, positive symptoms would be those symptoms with added effect, like additional thought processes, hallucinations, additional um, cognitive association delusions. So that's what differentiates between those negative and positive symptoms of schizophrenia. All right, we'll go into anti-seizure medications. There are several questions on phenytoin. Phenytoin, as you recall from our lecture, has this one of the side effects of gingival hyperplasia. So always encourage good oral hygiene. Um, let's see what else. Status epilepticus is controlled or certainly managed at least as good as you can at the time with a benzodiazepine, lorazepam. in particular. Lorazepam is also one of those drugs that are used in delirium tremens as well, which of course you know is not a seizure disorder, but it's overexcitability of the brain or the central nervous system. Anytime your patient is on any sort of anti-epileptic drugs, obviously you don't quit. They're not abruptly withdrawn. Certainly abrupting anti-seizure medication can cause rebound seizures that can turn into status epilepticus as well. Phenytoin is one of those drugs that are bad actors, particularly with Coumadin or warfarin. Oral contraceptives are something that's also contraindicated, as well as steroids. We've talked about those three drugs all semester as being those drugs that don't play well with others. So remember that going forward, not only for your exam, but in your other classes as well. Phenytoin also can cause liver complications. So if your patient already has existing liver function problems, then of course this is a medication that wouldn't be favorable in that particular patient. Benzos, of course, like most of the drugs that we have talked about for this particular exam, always gradual dose reduction. Certainly, the side effects of abrupt withdrawal are can be emergent. We speak again this exam about gabapentin. We've talked about gabapentin before. It does cause drowsiness. It's used in seizure disorders as well. Certainly the milder versions or the milder forms. But remember that it does cause drowsiness. And the good news is that patient teaching is required. So certainly the encouragement would be to take it at night when your patient is not operating heavy equipment or driving a car. Carbazepine certainly is another one of those medications that cause bone marrow suppression, so watch out for that. Phenytoin toxicity, that looks like respiratory depression. And as you can imagine, these drugs slow down the central nervous system, and that can also cause nystagmus as well. Let's see, alcoholism we've spoken about several times throughout this semester. Wernicke-Korsakoff syndrome. The Wernicke part is the part that can be reversed with vitamins, vitamin therapy, and good nutrition. A friend of mine's daughter actually didn't drink, but she developed Wernicke's. She had 2 gastric sleeves and developed a profound nutritional deficit. Unfortunately, she didn't reverse it, and it actually turned into Korsakoff syndrome. And unfortunately, now she's has lost a good bit of her memory that will probably not, she will probably not be able to regain it again. As far as these seizure disorders, you know, even when you have an accurate diagnosis, it may be difficult to find an effective drug combination. A lot of times it's kind of start one, maybe decrease it and add another. But the goal, of course, is to minimize the seizure activity so your patient can have a normal life as possible. If your patient can kind of stabilize on a particular course of medication for these seizure disorders, they can live a pretty good life. They always have to make sure they take their medications. You know, of course, no alcohol, you know, no excessive strenuous exercise, anything that can throw their electrolytes off or affect their central nervous system. Phenobarbital is another drug that's also often given in combination with particularly a drug called valproic acid. Phenobarbital unfortunately causes relatively extreme sedation. So, you know, one of the better things to do when you're trying to juggle these medications is to back off that particular medication, phenobarbital. It has a tendency to have the least effect when lowered in combination with other medications. Excuse me. And once again, any of these medications can cause a rash. Always think Steven Johnson's. As far as benzodiazepines, always think about respiratory support and other medications. Any other medication, particularly these medications like anti-seizure medications that have a pronounced effect on your central nervous system. If your patient is on, in addition to these drugs, on Lasix, remember, always report any sort of side effect of the medication, particularly like something like oxycarbazepine. If they report nausea, drowsiness, and headaches, remember that the Lasix um, um, uh, can cause sodium loss, but these antipsychotics can also cause sodium loss as well. So your patient could be profoundly hyponatremic, and that could set them up for arrhythmias as well. As far as phenytoin, I mentioned earlier about the oral contraceptives, and I also spoke about Coumadin and prednisone as well. Like I mentioned earlier, the goal is to minimize the seizure disorder to where your patient can experience a relatively normal life. It's a good idea to encourage your patient to wear a medical alert bracelet, and and certainly sometimes in adolescence, as they're going through puberty, sometimes newly diagnosed children will be on a couple of medications, and particularly as these adolescents are growing and the hormones are raging, um, they're on two actually to prevent drug-resistant um epilepsy, or the form of the anti-seizure disorder uh, as well. Let's see. I spoke about serum levels. That's the gold standard to see if your patient is therapeutic. Anytime you're giving anything IV, certainly IV push, in the case of an acute seizure disorder where you need to push some phenytoin, always make sure you dilute it and give it slow. It's usually hung in a as a drip, and at least 30 minutes to an hour. So that that covers our antipsychotic and our anti-seizure disorders. We're going to talk about multiple sclerosis, Parkinson's, and Alzheimer's right now. So we talked about Parkinsonism, we talked about cinnamon, levodopa, carbidopa. When your patient starts on levodopa, carbidopa, sometimes they develop tics. That means that the medication is just a little bit too strong. And so sometimes that is backed off just a little bit. Remember, these medications that work on the central nervous system sometimes can cause orthostatic hypotension. Um, Certainly they do, like the other drugs we just talked about, have a tendency to dump salt through the kidneys. Always make sure your patient is very hydrated. Sodium levels of electrolytes are fine. And it may be just increasing sodium and water intake. Certainly that's easy enough to do at the hospital. We spoke about cholinesterase inhibitors and Alzheimer's disease. Certainly, they don't reverse Alzheimer's. The best you can expect is to minimize the exacerbation, or prolong the worst part for as long as possible. They have only been shown to modestly slow down the progression of the disease. Um, and these cholinesterase inhibitors also have a profound effect on the heart rate as well. So if your patient is experiencing bradycardia and lightheadedness, side effects certainly of these cholinesterase inhibitors for sure. Multiple sclerosis is another disease process that we talked about. We talked about glutamate acetate and multiple sclerosis. Um, Once again, this particular disease or disorder can't be reversed. The best you can do is start these medications early to try to minimize the progression or slow down the progression. Permanent remission is certainly not what these medications were intended to do. Glatiramer acetate is one of the ones that you give that has, particularly when it's initiated, um, it can be it can cause the feeling of chest pain and suffocation. It's just a side effect of this medication, and I've only given it one time in the hospital, and I actually called a rapid response. The good news is it's an expected side effect of this drug. What you really only need to do is stay with this patient. Obviously, in the hospital, you have emergency room, um, emergency equipment available. Like I did, I called a rapid response. The good news is these responses are always very self-limiting, and about 10% of these patients experience these side effects. The good news is they go away pretty rapidly. Parkinsonism and Parkinson's disease, or we treat those with levodopa, carbidopa. If your patient is on, you think, or the diagnosis has been made on Parkinsonism, and levodopa, carbidopa is just not alleviating the symptoms after several months of therapy, it just may be that your patient has something else like multiple sclerosis. So, this is kind of an unfortunate situation where it's a diagnosis by exclusion. Um, and so you try something, and if it doesn't work, then you might have to try something else. These medications are often given by injection, sub-Q. So always make sure your patient understands, or someone in the family understands, has education on how to give these medications. Carbidopa, levodopa, like we mentioned during the normal lecture, can cause uncontrolled head movements, dyskinesia for sure. Always make sure that these are reported to the physician. It may be indicative of a change or a decrease in the medication as well. Um, Donepezil is given for dementia. One thing to always educate the family on: when your patient is newly diagnosed, particularly with dementia, they're not going to go home and remember to take their medications. Certainly, a lot of teaching is done to the family as well. And this is a very sad, certainly sad disorder. Patients don't remember their loved ones, and their loved ones have a hard time understanding that their loved one is just not the same. And sometimes it appears to be that they're no longer there. Donepezil is one of those drugs we monitor liver function tests on. So always make sure that you check LFTs on Donepezil or Aricept, which is the trade name, trade name for sure. We talked about interferons. One thing that these interferons are given injection by injection as well. The best thing or the easiest thing to do for post-injection response, whether it's itching or redness at the injection site, is usually just a little bit of Benadryl. Sometimes a little bit of Benadryl, a little bit of over-the-counter Benadryl goes a long way. We talked about levodopa and carbidopa. Certainly, these drugs may take a couple of weeks to work. Like I mentioned, if it's months, then that may be a problem. They may not have Parkinsonism, but remember the carbidopa is added because the carbidopa doesn't cross the blood-brain barrier, but it does allow the levodopa to get across the blood-brain barrier to convert it to dopamine. And remember, the dopamine is what is lacking in these patients. They're unable to use dopamine for the process of motor conduction, as far as movement, um, purposeful movement. Let's see. Uh, Memantine is a medication that modulates the glutamate across the blood-brain barrier, and it allows the calcium to be used in the brain cells. And a lot of these deficiencies are of calcium and dopamine as well. Let's see, one more thing. Remember, going forward, there'll be some delegation questions on your NCLEX when you get there in 2 short semesters. Always make sure that you know that you as the professional nurse does all of the community resource referrals. You do all the teaching. You teach the patient, the caregivers. You evaluate the effectiveness of assessments, treatments. Anybody else, as far as licensed personnel that work under you, they can give prescribed medication. They can also protect your patient from any hazards, falls, poor environmental issues. But you, as the professional nurse, monitor all licensed personnel. All righty, we're almost there. Antiviral medications and HIV medications, acyclovir we talked about. As far as antivirals, acyclovir certainly has the side effect of nephrotoxicity. One of the best ways to navigate this nephrotoxicity, if your patient is receiving intravenous acyclovir, is to make sure your patient is hydrated. Usually, it's given with infusion with infusion of fluids to make sure that it certainly doesn't cause your kidneys to become taxed. Let's see, antiretrovirals like Tamiflu. These need to be ostamivir needs to be started as soon as you can within the first 24 hours, 48 hours, because anytime after that, that medication is not effective. Let's see. Antiviral protease inhibitors. Certainly, I mentioned this on another medication today, Zyprexa. A lot of times they have an effect on the blood sugar levels as well. Protease inhibitors are also associated with hyperglycemia, and so always make sure that patients with new or abrupt exacerbation of existing diabetes, you always make sure you check for hyperglycemia in your patients on protease inhibitors as well. These medications also can cause elevations in triglycerides, these protease inhibitors. So certainly the easiest thing to do, besides putting them on a cholesterol pill, which further taxes your liver, always make sure you start off with diet and exercise. Hopefully that will get down the triglyceride levels and prevent the statins, because those certainly have their toll as well, as we learned about in pharm 1. Let's see. Acyclovir can be used during pregnancy. Of course, the other alternative cannot. Zivaldidine is one of the medications that's given for HIV. The zivaldidine has as a side effect anemia and neutropenia. So anytime your patient is on HIV medications, always make sure we do a CBC to monitor for anemia, certainly neutropenia as well. Ifivans is one of those medications that should be your patient should be monitored to be on oral contraceptives. Certainly, if your patient is sexually active and does not use contraception, always make sure we let the provider know prior to that, for sure. Let's see, antiretroviral therapy. We navigate those medications by CD4 cell count. Always make sure that your patient is going to comply with their antiretroviral therapy. If your patient is very non-compliant, drug resistance develops quickly, and certainly CD4 cell count is something that you would keep up with. But always make sure some of these medications are actually for HIV positive patients are actually given in community outreach centers where they can actually do direct observed therapy. Because even if your patient misses 2 doses, their CD4 cell count can fall considerably, and that places them at extreme risk for infection for sure. To evaluate the effectiveness of these antiretroviral therapies, certainly you do a viral load testing, which is where the CD4 count comes into play. It's important to know and certainly to plan the care. Make sure that they never, ever, ever miss a dose. Antiretroviral can also cause problems with blood count. Interferon is when it's given for hepatitis certainly can cause leukopenia. And a lot of these drugs that we've talked about all semester long have a profound effect on blood counts and on bone marrow production of cells as well. Like I mentioned, efavirenz earlier about oral contraceptive with that particular medication, education on HIV and all of the medications that are given for HIV. Certainly ask your patient about any over-the-counter herbal preparations they may take. We talked about this certainly in pharm 1, and we've talked about it in pharm 2 as well. A lot of these herbal preparations can actually reduce the levels of these drugs, so we always ask about that. Certainly these drugs, like I mentioned a little bit ago, these antiretrovirals will affect the liver. Always do liver function tests, and certainly always, always, always watch out for a rash. That is everything in a nutshell. We talked about at the beginning, I think before everyone jumped on, we talked about dosage cal questions. The dosage cal questions that were posted to practice or a very accurate representation of the dosage cal questions that'll be represented on your exam. So make sure that you're able to do those. If you need anything, reach out, of course. Does anybody have any questions? Because I know I've just talked nonstop for a while. Let's see, I didn't see that. It says some students were having trouble accessing the class earlier and wanted to make sure I asked. Yes, I did record it. What is the topic of board question mean? I said I was going to answer that tonight, and I can't. Let me look, because I've been through all of my notes. I think it was talking. Oh, I think I was talking about. I think when I mentioned that I was talking about. There's always board questions on monitoring licensed staff. Ashley. That's one question on monitoring licensed staff. Just to know what they can and cannot do. Does that make sense? Alrighty, so does anybody have any questions? Oh, the part of Abigail, I didn't go over the part on vaccines. The part on the vaccines is very well covered in the written assignment. The one I posted in writing, the one that was posted in writing, that's covered on that part. So I am going to stop the